Good evening, colleagues, once again. Let's start with antifungal agents. Okay, so the most common fungal infections we know are Candida and Aspergillus. One is a yeast, other is a mold. But other less common infections are Cryptococcus, histoplasmosis, zygomycetes, sporotrichosis. Among these, Cryptococcus is also a kind of a yeast, but one of the most common molds other than Aspergillus is zygomycetes, or what we call as mucormycosis. So that's another mold which is becoming very common in India. It is seen mainly in patients who undergo stem cell transplants, AML patients undergoing aggressive chemotherapy, and also diabetic patients. So India is fast becoming diabetic capital of the world, we all know. And zygomycetes has a particular predilection for patients with diabetes. Very common to see rhino-orbital mucormycosis in diabetic patients. So any patient of diabetes who suddenly has a loss of sense of smell, or there is a black ishar developing inside the nostril, should always check for zygomycetes. And usually these people have deranged immune systems and also uncontrolled diabetes. So you have to remember these. So most common are Candida, Aspergillus, I will say Cryptococcus in HIV patients, and zygomycetes. Okay. I love this slide. I borrowed this slide from one of professors in Germany who came to deliver a lecture on antifungal. So he said we can divide the overall antifungal treatment strategies into this, kind of a 2x2 table. So there are 4 paradigms: prophylaxis, empiric, preemptive, and targeted. And on the other axis, we have to see high risk, signs, symptoms, radiological or serological evidence, and culture. So what is prophylaxis? It is fear-driven, right? The only thing which is present here is there is high risk. Okay, so a patient who is going for aggressive chemotherapy in AML is at high risk of developing fungal infections. If you are going to any African country today, you are at risk of yellow fever. So you need prophylaxis. So it's high risk, okay, which is fear-driven. Next is fever-driven. Okay, we know one of the most common features of fungal infections, it's no different from bacterial, it's fever. Okay, patient, you can't explain this fever. Patient is on 2 antibiotics, still is spiking fever. So there is high risk, plus there is sign and symptom in terms of fever. There is usually no radiological or serological evidence, and of course, culture is not there. Then comes preemptive therapy, which is evidence-driven. Now, in addition to high risk and maybe some sign or symptom, there is a definite serological or a radiological evidence. Now, what is the serological? In India, there is a beta-glucan test. I don't know if it's available now in SGPGI. It detects fungal infections, both Candida and Aspergillus. It is about beta-glucan test. Okay, it's a serological test. Or galactomannan test, which is only for Aspergillus. And radiological is more suitable for aspergillosis, where you see the cotton ball sign, the various radiological features of aspergillosis. So there is some evidence, what we call as preemptive therapy, but still there is no confirmatory diagnosis, there is no culture, there is no histopathology. And finally, targeted, which is the gold standard. Either you get the blood culture or a tissue culture positive, or biopsy is positive. Okay, that's a targeted therapy. Maybe at some point of time, I would love to talk about all these 4 paradigms in neutropenic and non-neutropenic patients. That's another 1 to 2 hours topic, but maybe at some other time. But right now, I think this should help you that what are the 4 treatment paradigms. What is an ideal antifungal agent? First of all, it should be fungicidal, broad spectrum, should cover Candida and Aspergillus, high tissue concentrations, low toxicity, low rate of resistance, oral and IV formulations, and ideally should be inexpensive. Okay. What are the different agents available? Again, like bacteria, we have cell wall inhibitors. You have echinocandins in that class. You have cytoplasm. which act on the cytoplasm, all the azoles, DNA inhibitors, 5-fluorocytosine, and of course, drugs which act on cell membrane, which is amphotericin B and ambisome and that type of drugs. Okay. Okay. What is the susceptibility pattern? Now, please remember this, even without focusing on the slide. When we talk of Candida, the Candida word is divided into two: Candida albicans and non-albicans. Okay. Now, the susceptibility pattern also is divided into these two classes. So, albicans on one side, non-albicans on the other. Among Candida non-albicans, there are 4 species which are most common: Candida tropicalis, glabrata, cruzii, paracellosis, and now in India, which is very common, is Candida humulini or Candida auris. Okay, I'm repeating. Most common species in Candida non-albicans are tropicalis, glabrata, cruzii, and auris. Auris is not on this slide, but remember Candida auris is very common. Okay, look at albicans. Everything covers albicans. All azoles, amphotericin B, echinocandins. Everyone covers albicans. The drug of choice for albicans remains fluconazole. Remember, high dose, not 150 mg to 50 mg BD. No, you ideally give, if a patient has systemic infection because of albicans, give 400 to 800 mg loading dose and then 400 mg maintenance. Okay? Tropicalis is one of the most common species in India. So fluconazole covers tropicalis, but the resistance rate is inching towards 10-15%. We had a paper from PGI Chandigarh. Fluconazole had 12% resistance in tropicalis. Guys, remember one thing: there is a cutoff of 20%. You know, in microbiology, we said 20% is that particular benchmark. When the resistance crosses that barrier, it becomes very alarming. Why 20%? Because the moment the resistance crosses 20% barrier, the susceptibility of that antibiotic or antifungal falls below 80%, right? And that is when you cannot use that or should not use that drug as an empirical therapy. For a drug to be used as empirical therapy, at least its susceptibility has to be 80% plus. So any resistance level, bacteria or fungal, when it inches towards 20% and crosses that, that's when it becomes alarming. So in tropicalis, still fluconazole is 10-12% resistance. And of course, Itra, Gori, posaconazole, amphocasto all cover tropicalis. So even drug of choice for tropicalis is fluconazole, unless you have data from your own hospital that the resistance is very. Okay. Candida paracellosis, again, fluconazole is sensitive. Paracellosis is common in children for some reason. Okay, and we say the more the plastic in body, central line, urinary catheter, more the chances of paracellosis. Again, fluconazole is sensitive and you can use that. Now we come to troubled waters, which is glabrata and cruzii. So first of all, remember, glabrata and cruzii, you should not use fluconazole. Okay. Ideally, you should not use any other azole also for glabrata and cruzii unless you have detailed susceptibility charts. But for glabrata and cruzii, drug of choice has to be echinocandins. Okay. And finally, Candida auris, which is not shown here. That's a very sinister fungal pathogen, resistant to almost everything. Sometimes it is resistant to even echinocandins. Amphotericin B is also resistant many times. So that's a very difficult pathogen to treat. Still, we use echinocandins for them, or sometimes we see the susceptibility patterns. So this is the general susceptibility that we see. But again, in microbiology, you cannot borrow anything from your neighboring hospital also. Forget global. So I would urge all of you to ask your microbiologist to give you the susceptibility patterns of different antifungals for your hospital. Very quickly, 1 or 2 lines. Amphotericin B deoxycholate, you all know, still remains the most broad spectrum antifungal, more than 50-60 years old, gold standard, drug of choice for glucose still remains. The only problem with this drug, you know, is nephrotoxicity. You know, there are papers now which say 30% of the patients develop acute renal failure on amphotericin B. It covers everything, all Candida, minus Candida auris, all Aspergillus it covers, Bucor it covers, Some people say if you give a continuous infusion over 24 hours and saline preloading reduces nephrotoxicity, I mean, that's okay. So in patients who cannot afford MBZOM, you can still use amphotericin B, but most of the guidelines have de-emphasized this mainly because of the toxicity. So just remember, the efficacy of amphotericin B deoxycholate is same as MBZOM. The only difference is less toxicity. This lipid associated or there are three versions: lipid associated, liposomal, and there is one more. So all are lipid associations. The only advantage of these is that they cause less nephrotoxicity. Okay, nephrotoxicity is not absent but less. Okay, but these are one of the most expensive amphotericin B or even antifungals. Fluconazole, the good old drug, still remains drug of choice for most superficial infections or even systemic infections caused by Candida albicans. But please use high dose in the beginning as a loading if you want to use this drug for systemic mycosis. Candida glabrata cruzii should not be used. Toxicity is good, but drug interactions are common. So your anti-cancer patients are on many drugs. And remember, azoles are very notorious for drug interactions, especially voriconazole. You know, so just remember that. Itraconazole, again, somewhere here, somewhere there, kind of an antifungal, covers yeast and mold. The problem with itraconazole is GI tolerability is very less. It's not easy to take this drug. It still covers aspergillus, so it's a cheap option still. But the problem is GI acceptance of this drug. Voriconazole, it's a drug of choice now for aspergillosis. Covers Candida. Glabrata and cruzii are question mark, but covers aspergillus well. Does not cover mucor, so remember that. It has a good CNS penetration. IV voriconazole, as you know, voriconazole is one of those drugs which has a good IV and oral conversion because bioavailability is not much difference. IV voriconazole is nephrotoxic because of a cyclodextrin molecule in that. It has a lot of drug interactions with the anti-TB drugs, and you can see with the carbamazepine and cyclosporin. You have to take a look at the liver functions when you use them. And many people say if you can check the blood levels, it is advisable to check the blood levels of voriconazole if you are using it in sick patients with aspergillosis. Okay, so that's voriconazole for you. Posaconazole is a new drug, not new anymore, but I think now the oral, it was available in oral solution form, but I guess now oral tablets are also available, at least in West. Again, broad spectrum, broader than voriconazole. It covers mucor also in addition to aspergillosis. It's a drug of choice for prophylaxis in neutropenic patients. So remember, if you have to give in allogenic BMT or in patients with AML undergoing induction chemotherapy, posaconazole is a drug of choice now. A1 recommendation in most guidelines for prophylaxis. Okay, it's also a reserve therapy for mucormycosis. It has less drug interactions than vori. There is a new drug, isovaconazole. I'm not sure if it's available in India. I don't know, but isovaconazole again is like posaconazole, covers mucor, covers aspergillus, and it is fast increasing its presence in the guidelines. You know, it's inching towards voriconazole to be becoming the drug of choice for aspergillosis. Caspofungin, one of the first echinocandin, very broad spectrum, covers Candida aspergillus, covers all. Remember, echinocandins cover all Candida, all yeast except Cryptococcus. Okay, they don't have a good penetration in eye and CNS.
You're not audible.
Hello. Okay, toxicity is minimum, but you have to give a loading dose. The biggest advantage of these drugs is no dose adjustment in renal dysfunction. So if you're in ICU, you can sleep well, irrespective of the patient's renal parameters, you can give this drug. Okay. Micafungin is sister drug, caspofungin. Again, it has been FDA approved in addition to Candida, but also for prophylaxis. There are some reports of liver tumors in rats, but again, it's light sensitive. Also remember that, but very much like a sister drug of Caspo. Anidulafungin, the only advantage of anidulafungin over Caspo and Mica is that it is hepatostate.
I think there was a connection issue we missed almost from caspofungin. So there was some connection. Yeah.
Okay. So micafungin is almost similar as caspo. There are some reports of liver tumors in rats, but again, there is the black box warning for that. So you have to reduce the dose in patients with hepatic dysfunction. Anidulafungin, the main advantage of anidulafungin over caspo is that it is hepatosafe. So if you really want to sleep well as an intensivist, not wondering about liver and kidney levels, and you have to treat the patient with systemic candidiasis, anidulafungin is a good option. Otherwise, efficacy-wise, it remains same as caspo and mica. A quick table to compare a mechanism, formulation, renal insufficiency, hepatic, CSF, and urine. I think this is self-explanatory. It's a good table as a ready reference if you want to compare different antifungal agents. Again, a quick look at the in vitro activity of different antifungals. Broadest spectrum antifungal is, so I'm making now one-liners. If you want to make, you can make your notes. One, broadest spectrum antifungal is amphotericin B. First pearl. So I'm just giving you some pearls and pitfalls. Broadest spectrum antifungal is amphotericin B. Drug of choice for Candida albicans is fluconazole. Drug of choice for aspergillosis is voriconazole. Drug of choice for Candida non-albicans is echinocandins. Drug of choice for prophylaxis in neutropenic patients is posaconazole. Drug of choice for mucormycosis is liposomal amphotericin. Okay, so these are some of the pearls and pitfalls or the summary of our antifungals. One chart on the dosing recommendations. Just see, most of the echinocandins need a loading dose. Okay, even liposomal amphotericin B, when we give, we start with a higher loading dose and then followed by the other dose. Azoles, if you are giving in sick patients, the recommendation is to check their blood levels. Again, this table, I mean, if you want, you can stick this table that prophylaxis, empiric, targeted, different drugs, which one is the drug of choice, which one is second choice, first choice. So this is a good option. This is what I just repeated previously. I'll again repeat. Drug of choice for prophylactic in neutropenic patients, posaconazole. Drug of choice for empiric use in non-neutropenic patients. If patient is very sick, echinocandins. Not very sick, fluconazole. Drug of choice for empirical use in neutropenic patients is echinocandins or amphotericin B. Drug of choice for Candida non-albicans, echinocandins. Drug of choice for confirmed aspergillosis, voriconazole. Drug of choice for mucormycosis, posaconazole.